Today we'll be talking about artificial intelligence, and some of the speakers are speaking elsewhere, and some of them had to cancel because of a corona scare that got raised, because what happened was just before the conference there was a report that there were 700 or 800 cases that were reported, and some of our members they became a little circumspect about it. So without further ado, can we have सर आपसे शुरू करें या मैं करूँ? All right. Okay. So the first topic for today is we'll be going through artificial intelligence, the techniques involved, the uses, the current guidelines which are available, and we'll broadly discuss where exactly we are headed in areas where guidelines have not been issued. So first thing we'll talk about is what is artificial intelligence, then we'll talk about how artificial intelligence and telemedicine are related, and then we'll talk about different branches or different subspecialties, and what are the clinical implications just now and what are the emerging clinical implications. So all right, thank you. So the first talk is, of course, always it's the introduction to artificial. No need to set a timer here.
We have enough time.
We have enough time. इसके बाद तो वही है. हाँ हटा दो, टाइमर का जरूरत नहीं. Can I have a pointer? Yes. All right. Good afternoon, ladies and gentlemen. The first talk was about introduction to artificial intelligence. This was to be taken by our president, who's busy elsewhere. So, on his behalf, I will be talking about the introduction and introduction to artificial intelligence, big data, the optics of big data, the AI techniques that we're using in ophthalmology. That is what I'm doing is I'm clubbing the first and the last and the techniques that we're using. So we'll be going back and forth in the topics as they are listed in the instruction course. Now, I do not have any financial disclosures to make in this presentation. The first thing that comes to mind is what is artificial intelligence. It has variously been described as the ability of a digital machine or a computer to do things which hitherto required human intelligence. And the best test for it was given by a gentleman called Alan Turing. He said that if you're talking to a machine and you're not able to make out whether it is a machine or it is a human being, then that is artificial intelligence. That has already been surpassed. And now we, in this age of driverless cars and if those who bought this also bought that kind of suggestions. So we are repeatedly shifting the paradigm of artificial intelligence. Whatever we could do earlier is now becoming more and more possible for a machine to do. What happened, the first big pillar to fall was Garry Kasparov got defeated by Deep Blue. And once the world champion was defeated in a game of chess, that's when the interest arose. Then it went a step further. There was another game called Go. It was a strategy game. People used to spend entire lifetimes to master that game. And Go was mastered by the system over a period of a couple of months, and then a heuristic analysis was done, a heuristic algorithmic learning was done. We just gave it the rules, and it iteratively taught itself, and that version was called AlphaGo 0, and that defeated the trained experts. And what was interesting was that the positions it would take were intuitively incorrect. That means what we believed would be a losing position, the machine was able to convert it into a winning position. That means it created data points which human intelligence would not have created. Now, when we talk of artificial intelligence, there are many ways of defining it. We are today in the era of what is called artificial narrow intelligence. Now, what that means is, if a machine is trained in playing chess, it will iteratively improve itself in playing chess and become and manage to beat all kind of human beings in that particular game. If it is able to transfer this intelligence from whatever it has learned from, say, chess into another field of domain or into another area, whether it is, say, playing cricket or it is performing surgery, then it would be artificial general intelligence. And we have not reached that stage as yet. In a few years, maybe we will. And then, of course, is the distant utopia or dystopia where machines would iteratively improve themselves and learn and live according to an ecosystem of their own. That's your Tron legacy or whatever you want to call it. Now, when you divide the narrow artificial intelligence, that is the era in which we exist, they can broadly be divided into these ones: robotics, planning, machine perception, knowledge engineering, and machine learning. Now, machine learning it includes, supervised learning, where you label the thing, where what has been done in diabetic retinopathy and all. We are all labeling those, and then the machine just picks it up and says, okay, this looks like an aneurysm. These are the parameters which have been given, so it is most likely this. So that is supervised learning. And in unsupervised learning, what it does is, it creates, the data is not labeled. It iteratively, it will go back, it will look at the rules, or it will look at the data, make clusters, then draw rules from those clusters, and separate the groups that are there, right? And then, of course, if it does both of them together, then that is deep learning. Now, how does that happen in medicine? You see, whenever any patient comes to you, he or she gets a prescription. So, in effect, what is happening is a transaction is taking place. A transaction in information technology is whenever data is either created or it is modified in a system. So when he comes to you, you give him a prescription, or a prescription is created, data is created. Next time he comes, you change the prescription, now data gets modified. So basically a lot of transactions will take place. And then I will take you back to what we used to do in the past. We used to log into a system, and then we would put this data into the computer, and from that local computer through a network, it would go and reside on something like a centralized computer, which was a server, right? And from the server, in the server, how was it lying? It was lying in the form of Excel sheets or database files, right? This was when it started. Then came images, then came videos, right? And we started using different type of data schema. And we started using file FTP servers. Now this is what we are using today. Everybody, all computers, all of us who are using computers. When it is on a server, you cannot do very big analysis on it, because the computer will crash, or it will not perform the request that the other people are asking for it to perform. So if you want to convert this into an algorithm, you are going to take the data which is on your server and put it in another computer or another network of computers, and that is called warehouse, and that a data warehouse. And now data warehouses in the last decade have come up in a big way in ophthalmology. And in the data warehouse, we are going to perform different type of analysis on it. So basically, on whatever was lying on your server is cleaned, it is prepared, and then it is put in the data warehouse, where you run different type of data mining tools, and that will give you different type of algorithms. And these algorithms you deploy on live servers, and when you feed the data, then the live server tells you, okay, this machine, those who bought this also bought that. So So it was calculated not on the live server, it was calculated at the back end, and now it is being used on the server to help predictive analysis for the client, for the customer. Same thing is happening in ophthalmology also. Now the question arises, why all of a sudden, in the last 10 years or 15 years, we've started talking so much about artificial intelligence, of the tele-ophthalmology. Now look at this. You captured some images, you put it on a server, right? Now anybody can take it from the server and answer this question here. So this becomes the store and forward model of tele-ophthalmology. So tele-ophthalmology had one system was very resource intensive. You would have video conferencing, patient would be seen, you would be talking to him, required a huge bandwidth. The other was this model. And this model works in resource constrained environments, and that is why tele-ophthalmology suddenly comes of age the moment we have a larger bandwidth. Now what has happened? Lot of data is getting generated because of, diagnostic imaging, mass screening, electrodiagnosis, genomic analysis, our OT notes, our clinical data. All that is getting generated. It is getting recorded electronically in EHR, EMR, PHR, whatever you want to call it. And at the same time, it is also coming from things like what you are wearing, your wearable devices, what you are buying, what transactions you're doing, your demographic data, your health records, and all that can be used to get a big picture of the person. So instead of, prescribing a medicine to an age group or a set of persons in a geographic location, now it is possible to talk in terms of personalized medicine, where we can tailor the condition, the treatment according to your even genomic analysis. That is what we will be coming to maybe in a few years from now. So personalized medicine is going to happen because lot of data is getting stored. The cost of storing data is coming down exponentially, and we are having bigger and more powerful machines which are able to crunch these numbers in a big way. Now, this brings us to the concept of big data. Earlier we talked of data which was residing in Excel sheets. Now what has happened is we've talked of so many types of data which is available, and when you want to integrate it, when you are looking at 5 different type of imaging modalities, you're probably looking at topography, you're looking at an FFA, you're looking at an OCT, and you're manually integrating all that. Now what has happened is all this data is stored. So when this is stored in a manner that it cannot be stored in traditional data formats, then we call it big data. Big data is something which is very large volume, which is very diverse, different types of investigations, different type of parameters are there. It is coming in very quickly, running into petabytes. And we've added in medicine 2 things: veracity, how accurate it is, and how valuable it is. So when it satisfies these, then it is called big data. And big data cannot be analyzed using the traditional statistical methodology techniques that we were using. So when we talked of data warehouse, the first data warehouse that we can talk of was something called the Smart Eye database, which was a web-based ophthalmologic data warehouse. And what it was doing was basically the university's own EHR was used, and it could create cohorts for you to decide कि आपने किसी कोई treatment parameters या कुछ check करने हैं, तो it could create cohorts and give you sets of lists which you would retrieve. Then of course in 2014, American Academy developed the IRIS, and this took 60 million patients' data on 50 quality control measures and 22 outcome measures. And the outcome, one of the interesting results from this was a study by Cantrell et al. And they reported that, you see, in newly diagnosed macular edema, the majority of eyes did not get anti-VEGF treatment in the first 28 days. And this was America, when everybody was talking that within first 28 days you have to give it. And when they were receiving it, it was actually Avastin and not ranibizumab. So this was real world data which we could capture because there were these registries that they had developed. Now this was the example of a registry from a single country. Now there is another registry which is across different countries. It's FRB, and it allows patients switching from one modality of age-related macular degeneration, going into another one, and the outcomes from it. So it is larger than any trial or any study that we've got, and we are waiting for results to come from FRB. Now, so far as techniques concerned, in analyzing that data are concerned, there are many techniques. We'll just concern ourselves. Why we are talking of these techniques is because, you see, everybody will say that, you know, Ting did this, and they could analyze this with this much percent sensitivity, this much percent specificity. It just becomes a list. What is more important for us to understand is what was the technique they used and how does it translate into practice for us. So what is very important to understand when artificial intelligence is involved is it should be explainable. The algorithm that is used, it should be explainable. Otherwise it becomes black box. And the interesting thing was, they did a study where they found that it could distinguish between a fox and a dog. And the reason why it could distinguish between the fox and dog based on labeled images was there was snow behind the fox. Right? So this should not happen with us. So that is why explainability is extremely important in all data management and AI techniques used in healthcare. The simplest one is, of course, linear regression. Linear regression is nothing but y explained in terms of x plus a constant. You remember we used to have this xy graph, and there used to be a slope. The slope would cut y at a particular thing at x is 0. So that used to be the constant. X is 0, that is the constant, and the slope would give us the graph. Now that is called, the simplest of that is if both parameters are or multiple parameters are continuous, then we can do linear regression. And then there are other types of regression analysis that we do. All of us remember our IOL power formulas, and there's one of the most convenient and most commonly used one uses regression analysis. Then there are others which are very interesting. Next one is nearest neighbor analysis. Ye padosi ki baat nahi kar raha. What it does is it looks at, you know, K means clustering. It looks at clusters. So what you get is a report like this. If R is less than 1, that means there are different data groups, data points which are clustered together, and there would be a difference between this and this. So this mean and this mean can be calculated. If R is 0, that means they are randomly distributed. If it is more than 1, then they are dispersed. Not only are they randomly distributed, they are actually having a negative impact on each other. Right? Then is, of course, support vector machine. You have this referable versus non-referable. Now, whenever you are able to classify between, you know, two groups, or you want to classify between two groups, what you want to do is you want to draw a line between them. This is called a hyperplane. So what does a support vector machine do? It clubs yes this side, no this side, and between those data points it wants to draw a straight line which is called a hyperplane, which will have a positive offset on one side and a negative offset on the other side. Now this is when they are lying absolutely separate. Sometimes there will be an overlap. Then they go like this. There's underfitting, overfitting on curves. Then of course we have decision trees. Decision tree is nothing but a flow chart where you have, you know, different type of weightages which are assigned to it. For example, it could be, you know, we have the best example that is given is the probability analysis is done for any action that you take. It could be, say, 0.6, 0.4, 0.7, 0.3, and then next step also has this, and this particular input would result in a particular type of outcome coming in, giving us the percentage in which we should expect that kind of outcome. And that is, if it is in a single case, then it is a decision tree. If you use lots of decision trees, some of them will be positive, lot of them are negative, you say it is negative. In that case, it is called a random forest. Now, this is a very simplistic description, but there are different algorithms, there are different programs which are written for each of them. And then comes to the big daddy of them all, which is being used left, right, and center. That is artificial neural networks, convolutional neural networks, deep neural networks like GoogleNet, LXNet, VGGNet, and CAFE and TensorFlow, and there are 4 more, right? And then, of course, we have naive Bayes, where the posterior probability does not matter. We've already talked of the types of data involved. Basically, what we are doing nowadays is, whenever we want to train a model, we take the entire data and 80-20 or 60-40, one part is used to train the data set, and one half of the same data is randomly kept aside to test whether whatever we've trained is a valid outcome and is working on this. Now, this is training and testing data within the data set. When this entire algorithm that we've developed is used on another data set or another population, then it is called generalizability of that data set, or that. Now, that brings us to the, now this is that when you've generalized the algorithm. Now, last year a very big thing has happened. Ophthalmology is one of the first branches to develop an algorithm which is US FDA approved, and this is IDXDR. This algorithm is for detection of diabetic retinopathy in offices of non-ophthalmic healthcare practitioners. And the insurance companies are going to give reimbursement for this. So this is a very big step forward. And this runs on non-mydriatic retinal camera, which stores the images. You click those images, then it puts them on a server, and from the server it tells you whether or not this is referable. So it tells you whether if it is mild diabetic retinopathy. If it is, then it will rescreen at 12 months. If it is more than mild, then it will refer to an eye care professional. And why did they stop at this? There were 4 studies that were going on. One of them had good, positive, and negative. All these algorithms had very good negative predictive value, but the positive predictive value was a little iffy. So basically, if we look at diabetic retinopathy, there are 2 eras or 2 epochs, prior to 2016 and after 2016. So prior to 2016, there were the positive predictive values were very low, and after 2016, the positive predictive values started improving a lot. And this thing, so important studies, I won't go into too much details on that. One is the IAIOC study, and then of course we talked of Ting et al. Now Ting was, this is one of the landmark studies which used 494,000 retinal images to train, and it was using desktop conventional fundus camera photographs. IAIOC study was using the IPAX telescreening system, and again they were traditional desktop fundus photographs. Now, what has happened in more recent years is we've got the Remedio experience, where fundus on phone, the photographs, and the Indian ophthalmologists have a very big contribution to making that an internationally accepted and acceptable project, and it's working on CNTK now, right? And then we had the iSmart, the iArt AI diabetic retinopathy. This started with only 296 patients. Then we had that one where we did 10 lakh plus. Now these are the landmark studies: Ramchandran, Abramov, Bhaskaran, Gulshin. And look at, this is the negative predictive value, all in the high 90s. These are 2018 ke baad ki studies hain ye, but still look at the positive predictive values. They are on the lower side. So this is still work in progress. Everybody will throw this data at you. This was, the sensitivity, specificity, area under the curve was 90, 91, 97, 96. The point is, we are able to say no, we're not really able to say yes. So it is still work in progress. These are prior to that, and because smaller data sets were involved, again, we are looking at these. And now we have something called, now what has happened is, certain governments have taken, they have taken an initiative and they have decided that, this needs to be licensed like we license the devices. Now this is what is emerging from the US, and they want the algorithms to be licensed like the medical devices are licensed. So now what we've done here is, see, the data was collected, the model was tuned, the model was validated. This is where everything is working, right? From there, it is going to come to, bhaiya ye ruk gaya. Then it comes to this. On the live servers, it is live data, which goes into a deployed model, into model monitoring, and then whatever comes out of it is taken up for the green arrow for retraining this model, right? Yeah, once we start retraining this model, now look at this. So we have, the model is developed there. The first part is model development, then deployment, and after deployment there is iterative improvement of the model. And we've all been involved in development of the models, and again we'll be involved in iterative improvement of those models. There have been a lot of issues regarding, the algorithms, like data which is prospective is better. There is a difficulty in comparing the algorithms. There are challenges related to machine learning process. Then this data is fitted to this data set. इस डेटा सेट में से दूसरे डेटा सेट के ऊपर, मतलब if it works in China, does it work in India, again is a big question and would require, a lot of work. So all this has to be taken into account. Then of course are the logistical difficulties, more so in a condition where we are talking in terms of, the privacy concerns and anonymization. Then of course human barriers. Then is algorithmic interpretability. And then is these algorithms, see, if the knowledge gets locked in one proprietary algorithm and is not able to be transferred to other, then we are all going to lose out on whatever number of man-hours we've spent in doing it. So all those are very important, and that is why we need a national health artificial intelligence strategy which should cover all these things on top. Now, based on the type of condition and the type of risk, there is a risk matrix. So what they did was, which has been developed, and they say that, risk ranges from 1 to 4, and what you're trying to treat or what you're trying to diagnose. And based on that risk and based on the return is how the algorithms should be evaluated, and at the same time they should be paid for. So there is a risk and compensation analysis which is going on, and I think there are other elements to it. Basically what we've tried to talk of is, whenever we talk of artificial intelligence, we're just talking of, this thing happening in diabetic retinopathy, that thing happening in diabetic retinopathy. So we've already demonstrated and we've already talked about what has been used there. I've not gone into the details of the different studies which have taken place, because that is, if anybody is interested, you can give me your mail IDs. I'll forward complete tables. There are around 96 studies, and only, out of those 96 studies, only one IDXDR has made it to commercial success. Right. Now, after this, we will shift gears, and I will invite Dr. Farooqi, and he will talk about artificial intelligence in tele-ophthalmology in cataract surgery. And then we'll go back to ROP, and then we'll carry it on from there. Thank you.
Good afternoon, thank you, Dr. Bali. It was a wonderful talk. You dealt into, I think, a lot of technicalities. I'll try to make this topic of tele-ophthalmology and artificial intelligence in cataract with Indian perspective as simplified as possible. So I'll be discussing this topic. Now, in recent years, the artificial intelligence has had profound and increased impact in ophthalmology. It has evolved from automation of manual tasks such as processing of ophthalmic images to machine learning and deep learning. The machine learning is a subset of artificial intelligence that allows automated system to learn from available data by discovering the best parameters within a general model such as support vector machines or random forest. The deep learning is basically a subset of machine learning that involves deep neural network architecture. The multiple layers of network neuron performs feature extraction. This ability has led to significant breakthrough in performance on various image classification tasks in ophthalmology. The artificial intelligence has brought a breakthrough in many areas of medicine. It has delivered robust results in screening and detection of diabetic retinopathy, ARMD, and ROP. The cataract management is another field that can benefit from greater AI applications. Now, cataract is a leading cause of reversible blindness affecting approximately 12.6 million worldwide. Improved diagnosis, monitoring, and surgical management are necessary to address this challenge. Developing countries often suffer from limited access to tertiary care, a problem further exacerbated by ongoing COVID-19 pandemic. The artificial intelligence can help transform cataract management by improving automation, efficacy, and overcoming geographical barriers. The artificial intelligence can be applied as tele-diagnostic platform to screen and diagnose cataract using slit lamp and fundus photograph, classify referable cataracts by deep learning by convolutional neural networks. The Tele-Ophthalmology screening program exploiting artificial-based software could reduce pressure on tertiary referral centers, providing screening evaluation before referring the patient to specialized hospital services. The artificial intelligence algorithm for automatic grading of nuclear cataract differ according to the type of input images used, the slit lamp photographs or the color fundus photographs. Now, the automatic grading of nuclear cataract can be slit lamp based images, and various studies have been conducted by various authors. Like Fan et al. In 2003, he proposed an automatic nuclear cataract classification system based on slit lamp photography. They devised a linear grading function to detect nuclear sclerosis severity based on landmark intensity. Moreover, the machine grading reduced the time necessary for classification to less than 2 seconds versus previous 2 minutes. Now, there are other studies done by, for example, HRA et al. In 2009, who employed artificial neural network as a classifier to distinguish cataract from normal and post-cataract eye images. And it had 98% sensitivity and 100% specificity. And other studies have been done by Lee et al. In 2010. He applied a modified active shape model, a type of shape detection algorithm, to first identify the location of the crystalline lens and its nucleus on slit lamp photograph, and then to develop an algorithm for nuclear cataract severity grading using a support vector machine, a form of machine learning algorithm model, as has already been told by Dr. Bali. Now, Zhu et al. In 2013 also used the same modified ASM for identification of lens location, but they then applied the bag of features model for feature extraction and group spaciocy regression, a form of machine learning for feature selection and nuclear cataract severity grading. The Gao et al. In 2015 established a different system which is based on convolutional recursive neural network, a form of deep learning for lens structure detection and automatic feature learning. The support vector machine regression was then utilized for cataract severity grading. Kim et al. In 2019 said he rationalized that since cataract grading degrades the performance because these models simplify the opaque pattern of cataract into linear forms, he used the tournament-based CNN to grade the cataract more efficiently, which does not degrade the images. Now, Wu et al. In 2019, he validated a universal artificial intelligence platform for cataract diagnosis and management based on dataset derived from Chinese Medical Alliance for Artificial Intelligence, that is CMAI. Now, he used the images for deep learning for training the mediatic slit lamp, mediatic diffuse, and non-mediatic slit lamp and non-mediatic diffuse. Now, traditional cataract grading system with the deep learning system for cataract management it usually relied on the gold standard, the mediatic slit lamp mode. But in this study, the non-mediatic capture mode, even in the diffuse condition, showed comparable results. So these results suggest that the feasibility of using artificial intelligence agent via a mobile application, even for collection of images from a patient at home. Now, there are automatic grading of the nuclear cataract based on the fundus images, and various studies have been conducted. For example, Dong et al. In 2019, he developed an algorithm of artificial intelligence using combination of machine learning and deep learning algorithm using fundus images. Features in the images were first extracted by deep learning network based on the CAFE software, followed by cataracts detection, non-cataract or cataractus, and severity grading using a softmax function, a form of machine learning algorithm. The Ryan et al. In 2018, he developed an algorithm which used the convoluted neural network to form a deep learning for initial feature extraction, and then he used the random forest network, the machine learning model for prediction of the cataract presence. Pratap and Kohli in 2019, it was similar to Ryan et al. He applied their artificial intelligence system, a combination of CNN and SVM. He established through labeling of the visibility of fundus images to denote the 4 classes of cataract severity: the non-cataract, the mild, moderate, and the severe cataract. Now, Zhang et al. In 2019, he said, on the contrary, unlike the above mentioned studies, whereby a combination of deep learning and machine learning algorithm were used, he described a deep learning method system that was based only on the deep convoluted neural network only. He did not use machine learning, and this method he called as multi-feature stacking. Now, more the lens opacity, more the fundus image gets blurred, and he divided the cataract into 6 grades. If it was clear and distinguishable, it was labeled as non-cataractous. If the small retinal vessels was visible as slightly mild, if the small retinal vessels were fuzzy, it was labeled as mild, and if the optic disc and large retinal vessels were visible, it was labeled as medium, and if only optic disc was visible, he labeled it as slightly severe, and if the fundus was not visible, as severe. Now, the pediatric cataract screening and diagnosis. Visually significant pediatric cataract should be treated promptly to avoid irreversible myopia. The diagnosis is often delayed for patients who do not have easy access to specialized centers. The artificial intelligence have shown promising results and can help address these issues. The Lin et al. In 2020, he developed a novel artificial intelligence screening model to identify infants with a high risk of developing congenital cataracts. A set of 11 non-imaging risk factors, example, family history and preterm delivery, were analyzed using random forest and adaptive boosting algorithm to identify predictive factors, demonstrated that the potential to serve a complementary screening tool, especially in underdeveloped and remote areas. Now, considering the diagnosis, a highly accurate machine learning platform called CC-Cruiser was developed by Zhongshan Ophthalmic Center. The CC-Cruiser used a CNN algorithm to grade and diagnose cataract on satellite images. It was capable of diagnosing, grading, and initiating therapeutic decisions to manage pediatric cataract. And the time to diagnose was about 3 times shorter compared with the ophthalmologist's opinion. The enhanced artificial intelligence technology can provide an alternate model of care that reduces the workload and provide time and cost-effective management. Now, ePaharvai is an artificial intelligence-based application in India. It was developed by Tamil Nadu E-Governance Agency. It allows healthcare workers to identify cataracts on spot with 95% accuracy. The application is available on Google Play Store, installed in the healthcare workers' smartphones. The healthcare workers enter the patient detail, click photos of both the eyes, and submit it. The artificial intelligence system will process images and classify it as mature, immature, or no cataract. The ePaharvai application is poised to help 20 million 50-plus aged Tamil Nadu residents susceptible to developing cataract. However, this solution can just as well be implemented across other states, essentially limiting the burden on the healthcare system and reliance on limited number of ophthalmologists. Now, there are other applications of artificial intelligence in cataract. For example, it is used in IL-PAR calculation. Some of the latest IL formulas have used the artificial intelligence to enhance the predictive accuracy. And during intraoperative support, video monitored surgery and intraoperative assistance can be useful. The artificial intelligence deep learning techniques, videos of cataract surgery could be segmented into constituent phases for subsequent automated skill assessment and feedback to optimize the OR scheduling, and for the post-operative complications to predict the progression of the PCO and eventually need for the YAG laser capsulotomy. So the current and the potential artificial intelligence application in different stages of cataract management can be for screening purposes of the primary care, for detection of the cataract, for classification of cataract, for referring the cataract, intraoperatively for predicting complications and optimizing surgical workflow, and post-operatively to predict the PCO progression and requiring YAG capsulotomy. There's a certain limiting factor in the artificial intelligence in these programs. The computer-aided cataract diagnosis existing algorithms have not been optimized for the presence of noise in the digital fundus retinal pictures, which is a severe concern because even minor noise level might compromise the cataract diagnosis efficiency. Vulnerable to distinct biases with respect to training data that in turn might decrease the efficiency in improving patient outcome in clinical settings. The datasets that are used for the artificial intelligence algorithm generation may contain incomplete clinical metadata. Important that training data reflects the setting in which the artificial intelligence algorithm would be used. This limitation makes it difficult to extrapolate population characteristics to assess the disease spectrum. Now, several artificial intelligence algorithms created and tested using experimental designs and datasets, however, cannot replicate the real-world scenarios leading to generalizability issues. The machine learning datasets cannot effectively represent the actual human population. Hence, for patients beyond these groups, the results obtained from the application of the artificial intelligence algorithms become less predictable, which may lead to undesirable inferences. The real-world applicability and generalizability of these algorithms might be limited owing to the challenges in the development and validation. Prior to the real-world application, these artificial intelligence algorithms must be evaluated through randomized trials to assess the safety, cost-effectiveness, and efficacy in clinical settings. The recent studies have shown that artificial intelligence algorithms have potential to exhibit comparable or higher accuracy compared to that experienced by the clinicians. The optimization of cataract patients' management is crucial now more than ever. The COVID-19 has significantly increased the waiting list to access the cataract surgery. The international guidelines have suggested a reduction in the number of unnecessary visits for the patients. With advances in technology, there has been an emergence of several artificial-based imaging tools and smartphone applications to provide support for clinical decisions. Such applications can help deliver ophthalmology care across triage, diagnosis, and monitoring. Thank you.
Thank you so much, sir. If anybody has any questions, we could take them now. In fact, there's a very interesting slide he's got. That actually sums up tele-ophthalmology and AI in cataract. I was about to point that out. कि अगर एक फोटो खींचनी हो तो ये वाली खींचने वाली है.
Application वाली.
Yeah.
मैं दिखा. Yeah.
You yourself in fact said that in the studies based on
Mike देना यार.
Hey, this one is what you mean to say? This one or this one? It's money.
दिखा ना यार.
you said that noise is a factor.
Yeah.
And this noise, what I have understood, is created by the media opacities other than cataract. Am I right?
Yeah.
Corneal opacity, there is a vitreous hemorrhage. So these are the things which are very big limiting factors in the fundus photograph based.
Any factor which hampers basically the imaging clarity is basically annoying.
Basically, this is media opacities only. Well, so that can be a very big limiting factor.
That's what I said. It is a very big issue.
But it should not be made an issue. This is what I want to come to, because anyway, these are the patients who again require a referral to an ophthalmologist, whether it is for cataract surgery or something else. So this is
one of the main concerns right now is the cataract. We are not tackling the corneal opacity with vitreous opacity or any other media. This thing. Our main focus is the cataract right now. So I am talking in relation to the cataract.
I fully agree with you. That's a very big limiting factor. At the same time, this can be utilized in a positive manner also, this information, that these are the patients who do require the care of an ophthalmologist, because cataract is still can be taken care after 6 months, but if there is a vitreous hemorrhage, it becomes more important for us.
You're absolutely right, Dr. Singh. I agree with you, but the question is, if a program, for example, the provider is based on the e-governance of the Tamil Nadu government, now it is a cataract-based application. So there, all the centers, all the healthcare workers, they are basically concerned only about the cataract at that particular. There may be application for other diseases also subsequently. This is one of the only starting point, let's say.
In fact, so that is true. See what happened.
National program also started with cataract and trachoma only. So these things now national program covers all the diseases. They find it ARMD and glaucoma is more important than cataract.
Sir, agreed, sir. Sir, any media opacity, we want clear visual access. That's all. So any media opacity in the visual access, should be evaluated. That's what
I want to say.
Sir, he was limiting himself to his topic, sir.
This is a weakness. It is a weakness, but at the same time, this can be used as a strength also.
So basically, for referrals, it becomes a
national cataract. We're not talking the national issue. I mean, in the ophthalmology, we're talking about specific for the cataract. In that case, I mean, the whole.
So that the limitation was related to that, sir, not to the other one. Yeah.
No, you're right. Suppose a corneal opacity patient is referred to a tertiary center. They said, "Oh, you have wasted my time here. I'm here for doing the cataract." So we have to be very clear. Okay, this particular surgeon, he is a cataract surgeon. I mean, you can't refer a corneal opacity patient.
In fact, I still
very
remember
specific, actually.
the first patient referred, like Tele-Ophthalmology came in later, but I remember there was the study in Reader's Digest. There was a there was a story in Reader's Digest where a child was referred because the photograph that was clicked showed a white reflex in one eye. And that child, this is in 1960s, this story has appeared, sir. So basically, like, so far as this thing is concerned, sir, any media opacity requires a referral to this thing. So we agree with your observation
Your
altogether,
observation is
sir.
absolutely right. It has good intention. The only question is, depending on what particular program you are basically developing that the artificial intelligence.
But sir, you are the advisor to the government. Probably you will be able to tell the government.
You can still go further ahead. You can involve all of the.
Sir, we are lower down in the what do you call it, in the hierarchy. You are the one who's going to have the meeting with the secretaries. So probably they could extend it to that also.
Yes, very
and
close
this
to
is just like these are all pilot studies, sir.
Yeah.
We're still developing the
This
applications.
is developed during the
for it.
COVID time only, this e-governance Tamil Nadu program, and obviously it has meant basically so that they are at least diagnosed before they really get into trouble.
Right.
That's what I've said, that it can be extrapolated to other states also. It's not only for Tamil Nadu. It's okay, it has been developed there, it's being used there, but it can be extrapolated and be used in other states also.
Actually, sir, because the camera, the light of the camera, like the mobile phone, the light as well as the camera bang next to each other. So it is almost like doing a distant direct on it. So you click a photograph, you're doing a distant direct, a slightly darkened room, you get it right. That could solve a lot of problems. Thank you, Doctor. Thank you, Dr. Farooqi, for yes, sir.
So it's said that the AI is just as smart as the number of people who are programming this or feeding the data or annotating images or how it is. So how many people give an input before you can refine an algorithm? That was one. And second, how much data do you need before you get predictable outcome from the...
Right, sir. Fantastic question. Let me answer it in two ways. So we talked of supervised learning algorithms and unsupervised. In unsupervised learning algorithms, no annotations. Supervised learning algorithms, you are labeling the data. The fewer number of people labeling the data, intergrader variability will be lower. If one person labels it, he'll label everything in that way and his kappa value will be 1. If there are 2, 4, 5, then you may agree, you may disagree. And then we have set up kappa values at X, Y or Z levels. And what we've realized over a period of time, I'll be coming to that. I think I will be talking about it in ROP, because you see, we worked, it was Indian ophthalmologists, the kid drop, if you remember the Karnataka experiment. So there we found a very interesting thing. Intergrader kappa, that is the variability between graders, because what they did was they converted the graders into 2 or 3 categories, trained them, and then certified them according to that category. There they could have, the intergrader variability was less and intragrader variability was more. That meant that the same person could make bigger errors within the same data sets. You gave him the same data set, you gave him the same images to classify once, and then, repeated it after some time. He was making more errors. This was because we were training. Whom had we trained? We had trained optometrists. I'll come to that. I'll show you that slide, sir. So your first question was, what is the number? So it depends on the quality of data. Quality of data simply means if it is replicable, if all images are centered at the same spot, pixel to pixel, then fewer number of images. That is not going to happen with us, because somebody has X fundus camera, somebody has Y, and now we have a very strange situation where we had those 2 megapixel cameras I'm not naming the company. Then we had 5 megapixel, then we had 8 megapixel cameras. Now all these images to the computer, it's not using vectors, it is using raster analysis. So the same thing becomes bigger for the computer. Then he has to scale it down. Then he has to make some interpolations. Missing data, it has to say missing data is X or it is Y. So we have a lot of problems. That is what I tried to cover in saying that prospective data is probably better. And that is where all the ophthalmologists come in. What happens is these companies will come. If you remember, Arvind's data taken by, I should not be naming it, X center data taken by Google, by X big company, Y big company, they put these people together, and what did we come up with? You see, we were able to actually find out how many, you see, we could pick up with vascular changes. Yeah. We predicted the systemic diseases from the fundus, but we could not match what we were trying to do there. That has actually happened.
That was not the intention of the study.
No. The picking up systemic diseases, prediction of systemic diseases was not the intention of the study. Oh. That was the side proposal. It was just like sildenafil. Sildenafil became Viagra and became a success. All right. So I'll just quickly wrap up tele-ophthalmology and AI in retinopathy of prematurity. No financial interests again. Whenever we talk of ROP, two major studies, whenever we're talking of telemedicine in ROP, Sundrop, that is the Stanford University, they linked 6 centers together, 1200 some odd photographs, analyzed them. And then we had K-Drop 2011, 2014, 2016. There were problems with both the studies, benefits of both the studies, carried them forward. And then the message that was carried by us and the message that actually finally has emerged are two slightly different things. Now, Sundrop 2005 to 2011, 1216 eyes, 26,000 images, positive, negative predictive values as shown here, high 90s. Karnataka, the K-Drop 2011, they gave us 7,000 odd infants, did not give us screening criteria, comparison criteria. In 2014, same thing, RedCam shuttle, store and forward mode. RedCam shuttle, click the images, forward them. They compared with non-physician grading of images versus expert live examinations. Expert live examinations with store and forward imaging. Now this is where what they had done was, they said we will grade our optometrists into 3 levels, and they would be given depending on their level of proficiency, they would be permitted whether they can say, you know, it requires a referral or it requires a discharge, right? And interestingly, at that moment in time, we criticized that model, but subsequently, the same model was used by EROP, right? So, apart from India, we have experience from Chile, Peru, and Germany. In Chile, 11 NICUs were there. Again, a RedCam shuttle was used, like it was used in Karnataka K-Drop. The evaluation was by 2 ROP experts, 5,000 imaging sessions performed. 98% of the images could be used for evaluation. In Peru, it was about 97%, which was suitable. And in France, it was a smaller study, a RedCam 120, but it gave us no positive predictive values. The German study was very interesting because it picked up all the 40 cases which required treatment out of 1200. But look at the positive predictive value. It was in early 80s. And then we went back and we tried to look at what the data said. It says only 21% of the NICUs are using retinal imaging devices today, and only 30% of neonatologists agree that telemedicine is safe for ROP screening. In practice, we all know the hybrid model involved in North Carolina, and that was the Sundrop model. And we have the EROP study where wide field retinal imaging was performed and interpreted by non-physicians with examinations performed by physicians, 1,200 infants who received a median of 3 imaging sessions with conventional live surgeries at 12 sites in the United States, 1 in Canada, and this was between 2011 and 15 immediately after that one. In practice, what is used is contact wide field photography, which is usual, the red cam and all. And given these were the sensitivities and specificities given at the bottom there, right? Now, the IROP, which was the Imaging and Informatics in ROP Consortium, reported a higher accuracy for zone 3 stage 3 disease if you performed live examination. So if it is the borderline which has to be decided, the live examination still remains the gold standard. And that has actually been translated into the guidelines also. Now, then of course we had the same thing, EROP also used it, the non-physician grader, we talked of those, training them, using lectures, giving them pre-certification, then giving them 100 images. If they crossed 85% accuracy, they were given that certificate. Right, now we come to that, where's that? Have a look at the second point. The weighted kappa is 0.72 for intergrader, 0.72, which is good, right? 0.57 to 0.94 for intragrader. Now you understand what I was saying. And now this doesn't stop here. So the trained physician will still, as of today, remains the mainstay. Now let us take it to our trainings. So it has become a tool for us for training also. We do not, and this is not me, this is a US study which is saying it. There is no standardized method of assessing competency among ophthalmology resident and pediatric ophthalmology fellowship program. So they came up with Global Education Network ROP group, and these are the sites, and improvement has been reported. Right? Now, what are the AI techniques used? Now, very interesting thing that they did was, instead of training it like this, before the convolutional networks came, we had something called ROP tool system. And what ROP tool system did was, it took out the size of the vessels, and based on the size of the vessels, it gave you a score. And that score conformed well with the grading. Now this was very interesting because we had 5 stages, 5 grades, then plus disease, no plus disease. Later we put all those things together and got much better sensitivity and specificity values, but the first one was this one, and this was not a convolutional neural network. And the CNNs were based on about 5,000 images here. And then we have 2 or 3 more which are based on, you remember AlexNet, GoogleNet and VGG16, and we have for identification purposes it's IDNet, and for grading it's GDNet. And look at the sensitivity and specificity in the late 80s. Negative predictive value almost 90%. But let us go back to the guidelines. And what do the guidelines say? The guidelines support the use of remote digital fundus imaging to identify individuals with referral warranted ROP. Yes, you can use it to identify referral warranted IOP, but have at least one binocular indirect ophthalmology examination before the initiation of treatment or termination of ROP management. That means, in the end, the guidelines have stopped just short of accepting. They still place, the human being as a trained ophthalmologist should discharge the patient from treatment. So that is the take-home message for it. And now let us talk of all of us know what those wide field systems are. RedCam, all of us are available with, are aware of RedCam, Shuttle, RedCam 2, whatever. Then Visionax, Finex, This, all of us know, a lot of us have been involved in development and progression of this particular thing. And this is very much an Indian phenomena. And now we also have a non-contact one which is performing fairly well in type 1, that is aggressive posterior ROP. And but still the take-home message remains that the human being, the trained human being, has to take a final call. Thank you so much. I'll take any questions, or we'll go through the next presentation and then take the questions. Right? We have with us Dr. Bhalla. He is the Secretary of Tele-Ophthalmology Society. And Dr. Bhalla will be talking to us about, he's a leading glaucoma specialist, and he's also he's the Secretary of the Tele-Ophthalmology Society. He's the member of the scientific committee, and he's been very active with training people in glaucoma. So over to you.
Thank you, Dr. Jatender Bali, for making me part of your prestigious instruction course. I'm going to talk on tele-ophthalmology and artificial intelligence in glaucoma. We all know this. Glaucoma is irreversible and progressive loss of vision due to damage to retinal ganglion cells. While early intervention could minimize the risk of vision loss, its asymptomatic nature makes it difficult to diagnose at earlier stage. So it's a multi-modality approach that is heavily dependent on the experience and expertise of the clinician. So this is what WHO definition of tele-ophthalmology. And what are views about tele-ophthalmology? AIOC survey done assessed the attitude of ophthalmologists in India towards tele-ophthalmology, and it predicted a surge in integration of tele-ophthalmology into the practice. There were 1,180 participants, of which about 18% were already using tele-ophthalmology. 99% showed interest to incorporate it into their practice, and about 99% were interested to adopt a mobile app-based teleconsultation. And the modes of consultation can be either video, audio-based, or text-based. These are the various projects which Dr. Bali has already covered. These are the projects in India. Now let's talk about tele-ophthalmology in glaucoma. The key metrics for diagnosis and progression are, as we all know, intraocular pressure. Yes, OCT imaging can be incorporated, and the visual field testing. And all of these diagnostic modalities can now be performed using portable devices by even patients sitting in the comfort of their homes. Regarding IOP measurements, yes, Goldman applanation tonometer still remains the gold standard. But now we have portable IOP measuring devices like eye care tonometer, iMate system, which is a wireless implantable IOP sensor, the Triggerfish Sensimed, and all these devices provide more than a single data point of information throughout the day and allow the patient himself or herself to play a crucial role in his glaucoma care. Optic disc evaluation. Mobile phones can now capture high-resolution fundus and optic nerve photographs using adapters, and these are the various devices: Eye Examiner, InView, DI, iScan OCT, and Envisu C2300. This is a handheld OCT system which is approved by the FDA for aiding in the diagnosis of glaucoma. Visual field testing, standard automated perimetry remains the gold standard, but it has to be performed in office setting. But now we have computer software and virtual reality tools which can offer home perimetry, and these devices are IBIS Vision, Crute Medical Systems Perimeter, which is a head-mounted device, Vivid Vision Perimetry, which do not require a computer, and it's even easier to perform perimetry at a remote location and in a portable fashion. So in conclusion, tele-ophthalmology can cross geographic and financial barriers that limit patient access to glaucoma care, and it promotes a co-management model between the patient and doctor for identifying, treating, and halting an often a potentially devastating blinding disease. It also gives patient an important role in their own care, so it can improve compliance, and reduction in office visits and time spent in the doctor's office will relieve a burden on the healthcare spending, decrease hours in the waiting rooms, and it addresses glaucoma with a team-based approach, including the patient and the physician. Talking about artificial intelligence, I'm sure this has already been covered. These are the various, it can be classified into two categories: machine learning classifiers and artificial neural networks. Machine learning is capacity of computer to learn from experience, and algorithms learn on their own by trial and error without being explicitly programmed the steps to do a task. Whereas neural network is a computer system modeled on the human brain and nervous system, and it is built as a network of neurons communicating with each other with multiple inputs which modify the output. So there is a feedback loop for learning. So this is input, like the fundus images are taken, which goes through the hidden layers, and we get the output. Like it shows, if we have the optic disc images, retinal peripapillary images, then it goes through the hidden layers, and the output is given whether the glaucomatous optic neuropathy is present or not. Deep learning is an advanced level of neural network, and it uses multiple layers to progressively extract higher level features from the raw input. So this machine learning can involve both supervised and unsupervised methods. And if we compare machine learning with artificial neural network, you will find that the machine learning are the clustering algorithms that are extension of classical statistical modeling, and it processes inputs and provide a specific output that serves to classify or grade the input. Whereas artificial neural network these are biologically inspired algorithms that pass the input data through series of interconnected nodes, and the weight of each node is then modified to obtain the desired classification. And if we see the machine learning characteristic, supervised learning uses fully labeled data, whereas unsupervised learning uses raw unlabeled data. So this machine learning is well suited for handling low dimensionally numerical data such as simple numbers like vertical CD ratio, intraocular pressure, age and sex. Whereas artificial neural network is well suited for exploiting high dimensionality data through interconnected levels of data abstraction. And it uses data like fundus images and OCT images. So machine learning characteristics uses simple numbers, whereas artificial neural network uses high dimension data. So this is what has happened. There is extraction of features which goes through the feature map, and the common features are pooled, which goes through connections and interconnections, and then multiple repetitions and multiple layers will yield a final output regarding presence or absence of glaucoma. So several artificial intelligence techniques have been proposed to help and diagnose glaucoma by analysis of functional as well as or structural ocular images. And goals of artificial intelligence in glaucoma is either detect glaucoma, or to detect progression of glaucoma, or to study risk factors for glaucoma and quality of life. Prediction of IOP trends from previous data and medications would be useful. Use of artificial intelligence, like using data from 24-hour monitoring of intraocular pressure at home by Sensimet triggerfish. So this is how the fundus image has been taken by a device by Netra, and then which uses artificial intelligence. These images are transported and then they can be analyzed. And the optic disc photography can be used to find out the disc size, vertical CDR, horizontal CD ratio, and disc damage likelihood score, which can help us in presence of glaucoma and also classification of the grade of glaucoma. Artificial neural networks, I've told, is used for classifying optic disc photographs. Deep learning, it extracts glaucoma related features from fundus color photographs, and these are the various studies like that of Ting et al. And which have used the area under curve, and which have yielded a specificity of about 87% and sensitivity of close to 96%. But the disadvantage is in having the false positives, like the false positives in physiological cupping, or false negatives as in patients of high myopia. So these are the various systems like Pegasus, Netra Artificial Intelligence. There is Indian startup which is Kalpa Innovations, and all these parameters can be used to identify or presence of glaucoma. Visual fields, if we take into account, the first use of machine learning is to discriminate normal and glaucomatous visual fields. In 2004, the visual fields were classified independently through unsupervised machine learning characteristics. Pre-perimetric glaucoma diagnosis can be made, and by using combination of TD plot, pattern standard deviation and mean deviation, we can have a forest classifier attained area under curve, and this can be done then. These are the various studies where they have used artificial intelligence for visual fields by Brigatti et al., then Wen et al., and there was subjectivity which was involved in obtaining the visual field data, patient factors, there was measurement noise, and the fixation losses which could make the higher fixation losses which could make the data unreliable and interpretation of visual field difficult. These are the series of studies which have been published for artificial intelligence for the diagnosis of glaucoma using the functional evaluation of visual fields. And so artificial intelligence used not only for diagnosis of glaucoma by visual field, if we can even have the series of visual fields to assess progression of visual field and thus thereby to find and analyze the progression of glaucoma. It can be used also by using data of structural damage in the form of OCT RNFL and RNFL ganglion cell layer. So there are multiple studies which have now been published, and a lot of work is going into using the structural parameters and analyzing by artificial intelligence. These are the series of studies which have been published for diagnosis of glaucoma using structural evaluations. Anterior segment OCT is also used of angle, where we can have various angle parameters can be assessed like AOD 500, AOD 750, then angle recess area. All this data is captured and then sent and then can be used for assessment of angle evaluation for diagnosis of angle closure glaucoma. So hybrid artificial intelligence approaches are also made, where we combine the artificial intelligence systems, combine both the structural by OCT and functional evaluation using perimetry. And artificial approaches are also being used in glaucoma genomics. But there are challenges in the clinical translation of the tools, because the performance depends on the quality of training data. Large number of images are required, and there is good mix of ophthalmic and non-ophthalmic factors like glaucoma severity, differentiating factors from non-glaucomatous causes of optic neuropathy, the non-ophthalmic factors like age, ethnicity, race, and curating such a training set in practice is very expensive. And these are the limitations. So the future work is being done to extract knowledge independent of human intervention, such that new insights and patterns of glaucoma can be evaluated. And comprehensive artificial intelligence for glaucoma should evaluate all these parameters like structural factors like optic disc, visual field, RNFL, ganglion cell layer, IOP and gonioscopy. And that would really help if we are able to combine the structural and the functional parameters and use artificial intelligence. That would indeed be a game changer in the fight against this blinding diseases. But unfortunately, such a system is not ready yet. Thank you, everyone. And I also take this opportunity to invite all of you to the annual DOS conference, which is going to be held at New Delhi. Please kindly block your dates. These are going to be held from 7th to 9th October. Thank you once again for your kind and patient hearing. Thank you.
Thank you so much, sir. Any questions that we have? So now I have a question. How do you visualize artificial intelligence impacting, and how many of you are willing to incorporate tele-ophthalmology into your practices? So 2 out of 3. Okay. And yeah.
The difference between what do you mean by tele-ophthalmology and AI? Tele-ophthalmology, you're referring only to an archival system.
No.
It sends it to the doc, and there is a doc at the back
See, there are two types of tele-ophthalmology models that exist. One is a real-time, that is a video conferencing kind of a thing. Your patient is at a remote site, he connects with you in real time and gets the advice in real time. This is expensive in terms of you have to be available, your entire linkage has to be available, and the bandwidth at receiving and giving end both has to be available all the time. Right. And the other method is the patient comes to your remote center, he is seen, but a few photographs or whatever is clicked, or some data is collected, and those are stored, and they are analyzed they are forwarded, that's stored here, and then forwarded to a central server. You look at it from whether your own computer or whatever, and then you can give an advice either to this center or directly to the patient. So that's a store and forward system. Yeah. The machine, in tele-ophthalmology, the machine does not interpret anything. Artificial intelligence is when, as of today, artificial intelligence is a decision support tool, because you have, like, India works on something called law of contracts. The contract is between the patient and the doctor. The AI algorithm is helping the doctor make a particular decision. Now, this is a gray area. If the decision is wrong because the AI told me it is wrong, like AI gave me information, this is not so, and I told the patient it is not so, but it was so, even though I felt it. That's why I talked of that black box approach. We have to be clear, we should be able to interpret it and biologically explain it. Plausibility is extremely important, at least in the current level of understanding that we are. And that is why we talked of that risk matrix. So if it is a more serious disease, for example, ROP, see, I am just trying to cover up the areas where we've had, slightly jumbled messaging. In some areas, so where it is more dangerous, where compensations are higher, where you are more likely to create a problem by missing, please remember the human being has the big red button, he hits the big red button. Right? We've already seen what happened with the 737 MAX. They had this system which was supposed to correct the nose. What happened was they shifted the aircraft's engine a little up, and now what happens is it tends to take the aircraft up. So they put it in the algorithm to take it down. And now it does not, now if it decides one of the sensors stops working, it takes the plane down, and we've had at least a few major crashes which caused a particular company's planes to be grounded. I cannot name it here, right? So MCAS, the MCAS system, that failed, right? So we have to understand that MCAS failed and caused that many deaths. It could have brought down that aircraft maker. It will definitely bring down a clinician. Yeah. We do not have class action lawsuits. Yeah. So, yeah.
Cataract, I think I've already spoken to. See, actually, your question was basically how does artificial intelligence come into play? See, artificial intelligence basically it reduces the workload of the tertiary care center. Here the doctor is busy. Now what's being done is that the artificial intelligence it decides that this person is, for example, having a cataract. So you straight shot, you tell the patient, can you please go to the center, you tell the doctor this person is coming, and he knows that this is a cataract case, and he just works on that. He doesn't have to basically search for the cataract among these rural patients or the patients in the far-flung areas, in the remote areas where he doesn't, the patient doesn't have the accessibility of the doctor or the specialized opinion. So this is the basic purpose. So we incorporate the tele-ophthalmology along with this artificial intelligence, and it basically ultimately decreases the workload of the tertiary care center and becomes more efficient in referring exactly what the doctor wants and what the patient requires, whether it be the diabetes or whether it be glaucoma or whether it be cataract.
So actually, even in the West, you see, it increases the availability.
Yeah.
Availability, as in, they have those. They were the ones who gave us the automatic teller machines. They gave us those automatic vending machines. So they'll probably give us those automatic referral machines also. So, but that's that's some time in the
fact,
future.
at one of the booths, I think one of the companies is promoting that anti-ray segment device be used at medical lab, a pathology lab or something, get the screening done and use that as a tool to divert patients to your this.
What would you say to that, sir, Dr. Bhalla?
So the question I had asked actually is that apart from glaucoma, this and cataract, for squint or neuro-ophthalmology or for are there any other areas?
Yes.
It can be used, sir.
Yeah.
If it takes, like in glaucoma, like just taking fundus imaging, it will not be sufficient because it involves analysis and evaluation of so many parameters. You have intraocular pressure assessment, you have fundus images, you have perimetry, and maybe even OCT. So imagine if all these images are taken and sent, and then if you can use artificial intelligence algorithm which pools these data, and then there is pooling and then extraction of features, common features, which will straight away tell you whether it is glaucoma or not. So it is not dependent on just one modality, which may have higher false positives or false negative. So it is using multiple features. Even in squint, I'm sure that if you take images in various directions of gaze, and then the images are sent, it will be better. And so the person sitting at medium level or tertiary care center can always say that this does require surgery and should be sent.
For squint, actually, the problem is the patient himself will know that there's a problem. I mean, you call it but the question is for glaucoma, he doesn't know. For the cataract, he doesn't know where is cataract or anything else.
No,
so there may not be put into this. I don't think so. This will be put into that. The patient himself knows that there is a problem in his eyes. I mean, not only his whole family member, his whole neighborhood and everything. They'll tell you, oh, you are having a problem. Please get it corrected.
There's a lot of work going on. See, we've not covered cornea. There's work in uveitis. See, we've in fact, what we've got is AI in diabetic retinopathy, AI in AI beyond diabetic retinopathy. So it is like beyond it. It covers uveitis also, because it picks up a lot of features. And then it is not. See, there are two things to it. One is the dimensionality of data. How many variables? Very large dimension, like if the dimensionality is very large, if the number of parameters, if it's low dimensionality data, feature extraction is possible, and then it becomes simple number crunching. If it is high dimensionality data, that's where that's the fun of doing it. Now we've got these regenerative, and we've got GANs coming in, doing beautifully. What they're doing is concatenating it. They make one algorithm fight against the other one, and which one performs better is the one which goes to the next stage.
I'll just like to add one thing more. See, what I have covered, for example, or Dr. Bhalla or Dr. Bali is covering, is tele-ophthalmology along with artificial intelligence. But there are certain areas where only artificial intelligence is required. You don't require tele-ophthalmology. For example, I have already specified in my presentation. For example, in the calculation of the intraocular lens power, it's being used there. Here, there is no question of tele-ophthalmology. It's simply the artificial intelligence is being used. Again, during the surgery part, what they do is they record the video, and then you make it into segmentation, and then you tell the person where all you have made a mistake. It helps in training basically your what do you call that, subordinates, the trainees, and all that. And not only that, the software is coming up for artificial intelligence, where you can tell the artificial intelligence can predict where all there is a possibility of complication that is going to happen.
In fact,
it's required during per-operatively for the so-called any complication that may occur pre-operatively for intraocular power calculation, and even post-operatively to suggest what is the possibility of the PCO in these cases, and when to let's say incorporate do the YAG PI in this case. I think I've already specified in my presentation these things.
Actually, there's a very interesting one which has already been developed. There's this thing. There's an annotation tool what it does is it the surgical videos, you know how time consuming it is to annotate them. So there's this thing which has analyzed the different steps of surgery. It can identify the different steps. It can annotate your surgical videos, and based on that, it can actually it's almost like using your Google Maps.
Yeah, telling you where you've gone wrong or where how to
Yeah.
improve in your aspect, basically.
So we're still some distance from it. Reason for it is that, you see, again, the quality of data, the interoperability, plus are we willing to use it? We don't want, if you remember way back, maps, there was, in fact, Apple had a big problem with maps, and they threw out the guy who was doing maps. I should not have named the company, I'm sorry. Okay, so one of the major smartphone manufacturers had to throw out the head of the maps division, and we don't know how much of an applicability it has. There are, you see, it is a multiplicity of tools which is available, multiplicity of processes which is available, multiplicity of places where it will be used, right? And the fun thing is, all of you are going to participate in developing it, because there's nobody else who's going to develop it. So I think that probably answers everything.
And even in squint, like you said, that it's very easy to make a diagnosis. But which is the squint? Like it is video, teleconsultation is video based and audio based. It helps to convince and motivate the patient to seek early intervention, where like in congenital esotropia require early surgery. So if there is a video based consultation with a doctor sitting, specialist sitting in a tertiary care center, it helps to motivate the patient, the parents to seek early intervention, which may be neglected, and the patients, the children may have amblyopia. So that way there can be indirect application of these tools in tele-ophthalmology, even in other fields besides cataract, glaucoma, and retina.
And in the end, all we can say is that, artificial intelligence cannot overcome natural stupidity in the end.
Sir, I've got a small question.
Yeah, please, sir.
But, I'm not a doctor, I'm a technology expert, and I made up EMR software.
Oh, fantastic.
That is health graph.
Right.
Running in Dr. Agarwal and so many other places. So I've got a question here that two things which I see. One is efficiency improvement, which I see this AI can bring in. Validation, doctors of course have to validate it. And does it bring some cost benefits so that treatment in terms of rural tertiary centers?
See, this is exactly, I talked of IDXDR. You see, what has happened in the US is they are actually having a big debate about who is going to pay for deployment of the electronic health records, or EMRs. And that was answered during Obamacare. They started giving those benefits. Now, when these algorithms were developed, now there is a particular cost to the algorithm. Again, the debate arose, who's going to pay for this algorithm? That the first, amongst the first two algorithms, IDXDR is it diagnoses referral warranted diabetic retinopathy in non-ophthalmology setups, and it allows insurance companies to reimburse for using that system. So I think that would answer the question in terms of efficiency. If somebody deploys it, see, somebody at the end of the day has to foot the bill, and it should not, must not, cannot be the clinician. Either it should be passed on to the patient, or the government has to find out a way of compensating it somewhere.
Fine. So
What do you say, sir? Dr. Bhalla?
What I reckon is there is a huge cost involved to it.
No, see. Whatever can be done in artificial intelligence can very well be done in India.
Fine.
And in the English-speaking world, we are the cheapest. The only people who are as good and probably even cheaper than us are the Chinese, and the Chinese were not there in 2013. We were the world leaders till 2012, 2013. Today, artificial intelligence algorithms, see, we all know what the Israelis were. They've been there. But we were very good. We still are very good. We are capable of doing the mule work, all this labeling and all. You talk of, I won't name the company again. It's the Indian ophthalmologist who labeled most of that data. So, I think that would answer the question. We are among the cheapest in the world.
And as the data increases, your predictability and accuracy becomes much better, which Dr. Farooqi has, I think, covered. Like in IOL power calculation formulas, which are based on artificial intelligence, like Barrett to some extent, Hill RBF, even Gain, EVO formulas. As the data increases, and then your it shows out of bounds by red and in bounds by green. That shows that the data of your patient mirrors the data in the pool which is there. And if it does not, then chances of less accuracy are more. Yes. And if it mirrors, you are bound to be very accurate with very less.
Accuracy predictability increases basically.
Refractory.
See, these things vary.
It's a dynamic thing, na? It's a dynamic.
Images.
Because,
Yeah, okay.
so the OCT images, so this was not from the offline point of view, but my son, and he's into AI. So we just thought, we gave him a lot of whatever, a single set of data of OCT images, and then he was trying this neural networks or things. The accuracy was not very great, and then he kind of...
It runs in lakhs. I think Dr. Bhalla pointed out in this minimum it was 1 lakh. It is in lakhs, in thousands. I mean, the more the better.
Ma'am, I'll tell you what the problem with your OCT images is. You have the macula, you have the macular grid, you have the raster scan, then you have area-specific scans. Then you have time domain versus spectral domain versus
swept source.
And
then same machine has to be there.
Yeah, exactly.
Similar images. Different machines, you cannot pool that data. So that is very difficult.
I'll tell you, this thing happened with me also. I was doing a project, and they had done some of it. And I walked in and I was like, I tend to, first look at, let's have a look at what we are doing. And I said, stop, we're not headed anywhere. Right? We started with, we ended up, I think, 118 on that artificial intelligence challenge. That was an international challenge, the one that, this Aptos, right? But I'll tell you what the problem was. Diffuse, the images are not properly segmented. They had, 6 or 9 data issues, then images centered in all kind of places. See, जो आपने clinical image लिया, वो standardization बहुत ज़रूरी है, उसके बिना और फिर क्या होता है, उसको label करने के जो parameters हैं, वो whether you label the whole image, you label a part of the image, you label series on series scan, pixel to pixel scan, where do you center it? So that's why. And then of course is this is the point is we have to pick up one of the techniques. Yeah. So what we are doing basically is we're trying to do feature extraction. Feature extraction cannot, you see, I click the same thing in 4 places. If I don't tell it for it, it's 3 or 4 features now. Otherwise, if I tell it that all these are 4 images of the same feature, it will put it as 1 feature. So that is, that's what I'm saying. You see, I'll come to you. You are collecting the data, you're storing the data. The point is, the quality of data is extremely important.
Very important.
In the end, it is, I'll give you the example of my own hospital. When we implemented HIS, हमारे यहाँ पे हुआ रहे यार क्या परेशान कर दिया. Every patient, the diagnosis was D/V, diminution of vision. So first 3 years, if you take out ophthalmology data of my hospital, it says DV, except one doctor, that was me. So I think we're done with it?
Yeah, we are done.
Okay, bye-bye. Thank you so much. Thank you, Dr. Farooqi, Dr. Bhalla, and thank you everyone for coming.